here. It's been a wonderful meeting so far. I'm here to talk a little bit about what we at University of call the ultimate toolkit for acute and subacute PVT. These are my disclosures, and the reason why we need a toolkit is because when you look at the guidelines, there's nothing very defined about what to do in the acute, subacute setting. The definitions are less than 6 months for acute, and chronic is greater than that. So when you wait that long, even the acute phase, you can have remodeling of the thrombus, and it's not really acute. And the other reason is there's not really any device that has a FDA indication for use in the portovenous system. When you look at the AASLD guidelines, there's not really a clear role for TIPS or a thrombectomy in the setting. I'm not saying that we don't do it. It's just that when you're looking through the guidelines, there's not much that's written about it. So what is the role of IR? We're a rescue therapy for failure of anticoagulation or progression, refractory complication of portal hypertension, bleeding, ascites, or impending intestinal ischemia. And so what are the risks of failure for this, of anticoagulation? If you have ascites, if you have splenic and mesenteric vein involvement, and you delay in starting any anticoagulation. And so ideally, these patients would get started on anticoagulation within the first 14 days, and anything outside that window, you have increased complications. And then also prothrombotic factors. There's a couple ways to approach how you access the portomesenteric system. There's the transhepatic route, and I think one of the advantages is that you preserve the endothelium and you have antegrade flow with your native portal vein. Generally, that's sort of, I think, where the advantages of transhepatic sort of end. Generally, in our practice, we prefer a transjugular access. There's no capsular puncture. You have stable sheath access. You can decrease your dose of thrombolytic. You can place a TIPS if the portal velocity looks bad or there's decreased outflow, and it allows for recurrent access. And so what is in the toolkit? We use a 16 French dry seal sheath, and the reason this is nice is you can fit a lot of things through it. We often will have this set up where we have our Bashir thrombolysis catheters, which I'll show a picture of a little later, but we can put those into the splenic vein, you can put it into the mesenteric vein, you can actually run it retrograde into the portal system, and you can combine 2 7 French catheters and 5 French regular thrombolysis catheter. So the side hole ones, and you can fit those all through a 16 French sheath and park them in different segments of veins, so you can thrombolyse multiple vessels at a time. And so this is kind of all of the things that's in our toolkit that we tend to use. You can use the Unifuse catheter, you can use the Craig Mack, you can use the Bashir, which is this right here, and it kind of is nice because it has multiple prongs that you can drip the TPA through, so you can actually distribute it through a large portion of the clot. You can use your ECOS catheters, your Inari systems, your penumbra systems. All of these suction devices can be used through the 16 French sheath. This is kind of a couple of the cases we did. These are some of the setups that we did, including Dr. Saad likes to use the Boston Scientific AngioJet system, where you can infuse the TPA throughout the clot, let it sit and wait, and then you can use thrombectomy devices to remove any of the large bore clot and then decide if you're going to lyse or not. And just kind of want to give you a couple cases. This is case number 1. It was a subacute thrombus with ascites and history of bleeding. You can see a large clot within the portovenous system with a lot of collaterals. And I generally like to use ice here, and the reason I do it is you can avoid things like the artery that's sitting right there, so you can see all these things. You can watch your access needle go into the clot. You can actually watch your thrombectomy devices if you are so inclined to see how much clot you're getting out. And then we use the penumbra catheter to section out portions of the clot. We were able to get retrograde into the right portal vein, and we left our catheters overnight. And this is kind of what it looked like the next day. We cleaned it up. Because of the underlying cirrhosis and variceal bleeding, we left the tips behind, and these are sort of the kind of the final pictures. You can also use it in the acute setting. So as you guys can see here, we have acute clot. We have our sheath parked right outside the portal vein, and we used our 16 French penumbra to get rid of the acute clot. As in this setting, we put tips behind, and this was the follow-up the next day. I call these the repeat offenders, so it's even nice to use in cases where the patients thrombose their tips afterwards. You can put the 16 French sheath in, you can drop your catheters into different vessels, you can run TPA, you can use all kinds of devices through that area, and it's pretty stable. And that is it.
Thank you for this very nice presentation, size and very good images. Any questions from the speakers or from the chairpersons or the audience? Thank you. Thank you very much. Now it's a pleasure to introduce my co-moderator, Professor Dr.